So greeting everyone once again and welcome to the 114th session of the online Optom learning series. And today we have with us yet once again, Dr. Daddi Fadel. I think not second time, but the third time she's been kind enough to do a session for us. And also Dr. Melissa Barnett, who has been with us for one session before where she did a session with Dr. Tom Arnold, right? So just for people who don't know, I don't think anybody would not know both of you, but just for the interest of the attendees who might have joined us recently, Dr. Daddi Fadel is a contact lens designer, a pioneer of modern contact lens designs, and she's a specialist in contact lenses for irregular corneas. She enjoys fitting scleral lenses and myopia control lenses and orthokeratology. She's a well-renowned speaker. She's been, speaking at all online platforms and invited lecturer, as well as a key opinion leader for many organizations as well. She has many peer-reviewed publications in the areas of specialty contact lenses, and she's also authored a couple of books. She is a fellow of the Scleral Lens Education Society. She's a member of the British Contact Lens Association and many organizations. She has been a very integral part in forming them, being board members, and helping the organizations to grow. So welcome, Dr. Daddi, onto our platform.
Thank you.
And most welcome. And Dr. Melissa Barnett is the principal optometrist at the University of California, Davis Eye Center. She is also an internationally recognized key opinion leader who specializes in dry eye diseases and specialty contact lenses. She also lectures extensively and publishes in the topics of dry eye anterior segment diseases and, of course, specialty contact lenses. She's also been awarded as one of the Women in Optometry Award. She's also a fellow of British Contact Lens Association, a board member of the American Optometric Association. And I mean, the list can go on for both of them, and it will take more than the lecture time to read out their bios. So I'm just going to be very specific in this. And I think the most important part I would like to share is both of them have been very, upcoming and sharing their knowledge across. With that, they have also recently been recognized by the British Contact Lens Association. They both are global ambassadors, 2 out of the 15 global ambassadors who's taking care of Europe and US. So that's very commendable. And both of them have also authored the book Clinical Guide to Scleral Lens together. So that's very important. And with all that knowledge, they are going to talk to us about the use of sterile lenses in therapeutics. So welcome both of you, and let me leave the screen time to you now.
Thank you, Fakhreddin, for this amazing presentation. It's such a pleasure to collaborate with Melissa. We had different projects that are already done, and we have very much projects together still to do. So, and lecturing with Melissa is such a fun. And thank you all for organizing so many wonderful meetings and for inviting us once more. Today, we will be talking about the therapeutic use of scleral lenses. So here are our disclosures, mine and Melissa's. So before getting in the presentation, let's have a reminder of what is a scleral lens, what is the benefit of scleral lens for ocular surface diseases. So the scleral lens is a rigid gas permeable lens that involves the cornea and rests exclusively on the conjunctiva. And between the lens and the cornea, a fluid reservoir is created called also clearance. This reservoir, during all the wearing time, allows to protect, lubricate, and moisten the ocular surface, the underlying ocular surface. This is crucial, especially in cases of dry eye and other ocular surface diseases.
And I'm going to chime in here and thank you again for this kind introduction. as Daddi mentioned, the beauty of that fluid reservoir is that it protects everything that it covers. So keep this in mind when we're talking about ocular surface disease, because the size and diameter of the lens does make a difference. If we have a larger diameter lens, it's going to protect more of the ocular surface.
Exactly. Okay, so recently with a colleague, we made research in the peer review literature, and we found 62 indications for scleral lenses. A major group that benefits from scleral lenses are ocular surface diseases. It's the precorneal fluid reservoir, as said before, that ensures continuous hydration of the ocular surface, alleviating symptoms and reducing clinical signs induced by the ocular surface diseases. Next, please. They have important advantages for dry eye secondary to different conditions.
We've published on Sjogren syndrome, but I cannot not talk about Sjogren. So the importance of autoimmune disease and dry eye, we have to just pause here for just a moment. So if you're seeing a patient just in general and they have dry eye to the point where you're thinking, okay, I need to manage it, whether it's a prescription eye drop or eyelid hygiene or nutritional or whatever it might be, let's think about some other things. So some of you have heard me say this before. I will say it again. Please ask if there's any dry mouth or any arthritis, other symptoms that go along with Sjogren's, dry skin. There are many different symptoms. And the Sjogren's Foundation is a wonderful resource if you're not familiar with Sjogren's syndrome. Now, for scleral lenses, this autoimmune category, so not just Sjogren's, but any sort of autoimmune disease, whether it's lupus or that undifferentiated connective tissue disease, put a scleral lens on in the office. Just try it out. And these patients have that instant, like, oh, that feels so much better. And so it's just such a great indication for scleral lenses. It's the whole autoimmune category, but keep in mind the importance of autoimmune disease in the just general population. If you look for it, you're going to see it quite a bit. Okay, moving on. Next slide.
So they are great benefits for persistent epithelial defects, inflammatory conditions, limbal stem deficiency, and ocular cicatricial pemphigoid.
Daddi, some people, when I talk about limbal stem cell deficiency, I often get the question of what is that? And so when you're looking at the cornea and you see that pannus and neovascularization and sort of the grayish appearance, especially at the periphery. So say people who have abused their soft contact lenses or that have severe disease, that is limbal stem cell deficiency. Of course, you can have limbal stem cell deficiency in combination with other conditions as well. And one word of caution in this population is that if they have a history of, say, soft contact lens abuse, wearing them all the time, I found that many of them want to wear their scleral lenses all the time as well. And so setting really defined hours of wear, whether it's 14, 16 hours a day, no sleeping in them, not wearing their scleral lenses for 24 hours a day.
Scleral lenses can be a great treatment option for vascularized limbal keratitis. The key here is to avoid tight fitting, limbal compression, and suction. The lens need to be well aligned on the conjunctiva and to distribute the weight of the lens in an optimal way on the conjunctiva. In this case, there is an increase in neovascularization and edema along the host graft junction in the post-keratoplasty cornea secondary to Fuch dystrophy. Edema and neovascularization disappeared after adding a smart channel below the haptic surface at the 3 and 9 o'clock to prevent and minimize the suction effect of the lens and to facilitate the fluid exchange. You can order directly the channels to the lab. If your labs are not able to make these channels, you can make them in your lab. These are channels, handmade channels. Also, fenestrating scleral lenses may help reducing suction. The fenestration in scleral lenses can be made in the limbal zone, but also in the haptic, like in this case, as suggested by Dr. Carschio, the fenestration in the haptic will help in reducing the lens suction. And in these cases, the lens should have a looser fit to avoid conjunctival sticking in the hole.
Daddi, just going back to fenestrations and channels, because that's something that we use in our clinic. And patients who've had a corneal transplant, and there have been many studies on this with scleral lenses, it can be a concern if there's pre-existing corneal edema. And that's a good point. So you need to evaluate the ocular surface, of course, prior to fitting any sort of contact lens, but especially a scleral lens. So those patients that have swelling before you put the lens on can be a contraindication. Now, at times, the scleral lens is it. That's your last hope. And by using the channels and by using these fenestrations, and we tend to use them at the limbus, as Daddi mentioned, it's helpful to make the fit, so a looser fit, so that it doesn't provide as much suction. Also, checking the endothelial cell status in this patient population is really important as well, just to see if they can tolerate a lens. And of course, you can always do an in-office trial or a trial for 4 hours of lens wear, putting the lens on, sending them off, seeing them back 4 hours later to see how their cornea does. Because I'm sure, Daddi, we've both had the experience of eyes going south and not doing well with the scleral lens due to this edema.
Definitely. Yes, so scleral lenses can be an indication in cases of ptosis. This is a 20-year-old woman with a bilateral ptosis for 17 years secondary to chronic progressive external ophthalmoplegia. A large diameter scleral lens with an increased vault was fitted, allowing a greater aperture of the eyelid.
And Daddi, you know what I'm going to say here. So in the US, we're fortunate to have an eye drop as well that helps with ptosis. So it's oxymetazoline hydrochloride, 1%, and unfortunately not in other places quite yet. But it's been amazing it's an alpha adrenergic agonist that works on Mueller's muscle to lift it up. So just think about this sort of patient where you could potentially use two things in combination.
Yes.
Okay, next slide.
We don't have it. I asked you when it
Right.
will be available, because we don't have it yet.
Not yet.
Not yet. So yes, severe ptosis so increasing the vault may allow a better opening of the eyelids, or for severe ptosis, like in this case, including a step on the lens may allow to hold the upper eyelid of the patients.
So this is a patient who had multiple surgeries, so multiple RK, LASIK, and here's just some examples of lipid keratopathy. And I bring this up because this is often a question that's asked too, like, what is that white thing? So here you can see the lipid keratopathy, and she has a really, really high refractive error and has been successfully wearing scleral lenses. The lipid keratopathy is getting a bit worse. It's a little difficult to tell from these images, but it is getting more pronounced. So the next step is a corneal transplant. Now you can also see that she's developing some cataracts as well, which I think is so incredibly common, especially now when fitting scleral lenses and cataracts. Once cataract surgery is done, usually it's just a power change for the scleral lens. But she's going to do well no matter what we do. It's probably going to be a combination working with the corneal specialist and then getting her refit into scleral lenses. So neurotrophic keratitis is an important condition, especially when we're talking about severe ocular surface disease and contact lens wear, specifically scleral lens wear. So it occurs when there's a reduced corneal sensitivity. We can get a spontaneous epithelial breakdown and impaired corneal healing. So in turn, the development of corneal ulcers, melting and perforation. And here you can see some really incredible images from Lynette Johns. Now this slide highlights the variability of NK. So I would really encourage you to examine all your patients who have dry eye. So NK in its mild forms looks like mild dry eye. It just looks, a little bit of staining, nothing really too significant. So you can see the image in the middle, that's even more advanced. Then if you go to the images on the sides, you can see the epithelial defects, which can be complete central and affecting vision as well. The image here on the right, this patient has graft versus host disease, been following her for many, many years. So it has successfully been wearing a scleral lens for many years. And this image was just when her epithelium broke down. But she's a monocular patient, one eye only. It's someone I worry about, and I see her quite often in conjunction with one of the corneal specialists. So a hint when we're looking for NK. So one thing I would encourage all of you to do the next time you're in clinic for your next 10 patients is just check corneal sensitivity. So using a cotton swab or using dental floss, minty or any sort of flavor dental floss, checking corneal sensitivity. Just check it out to see, but I've been checking it much more now than ever before and looking for the possibility of NK. So a few hints, as you can see from the images here, if the corneal staining is more inferior, it's more in conjunctival staining, it's more consistent with dry eye versus the more central or diffuse staining, it's more consistent with NK. And there are many, many conditions that can be associated with NK. Herpetic eye disease is really common. Diabetics, anyone who has any sort of solution toxicity, such as preservatives like BAC or on glaucoma medications. So it's something I'd like you to look out for and be aware of because you'll see it pretty often in your clinic.
Okay, this is a case of persistent corneal epithelial defect following penetrating keratoplasty. Scleral lenses were fitted to support the ocular surface and to facilitate the healing process. In this case, Vigamox was added to the lens reservoir before each application to minimize risk of microbial keratitis. The resolution of this condition occurred following 7 days of lens wear. After the revitalization wearing schedule was modified to daily wear, and lubricants ointment was added for use at night. And the outcome was that there was no recurrence of the persistent epithelial defect after 8 months of follow-up. This case is very interesting because it shows that it's possible for corneal opacities to resolve with the daily wearing of scleral lenses without the aid of other treatments. The key here is to avoid tight fitting, limbal compression, and to fit a well-aligned lens on the conjunctiva. Here's scleral lens fitted in a case with Salzmann nodular degeneration, where the lens was touching the peripheral cornea because of the presence of peripheral corneal elevation. A lens with a localized vault of increased elevation in the peripheral cornea, not the lens periphery, in the peripheral corneal zone was designed for this patient. Here the optic section showing the clearance in the increased vaulting area and the OCT image showing the localized vaulting of the elevated corneal area. This is a case of a neovascularization caused by a scleral lens of 16.50 millimeters of diameter, which induced limbal congestion. So switching to a larger diameter of 20 millimeter and increasing limbal clearance resolved this issue. Scleral lenses in dry eye are indicated as they protect the ocular surface, as we already stated before. So when fitting scleral lenses, it's very important to check for the presence of fluid wiper epitheliopathy, since this condition is considered a nearly sign of dry eye, which can compromise the result of lens fitting. So in these cases, the lens should be as large as possible to protect as much as possible the exposed ocular surface areas. Wettability is an important issue when fitting scleral lenses in patients having ocular surface diseases. The lens surface will now be as compromised as the ocular surface was before fitting scleral lenses. Wettability affects vision, comfort, and wearing time. It may increase the chair time and cost to find a remedy, and the patient will not be satisfied with the scleral lenses.
This is one of the most common questions, I think, in patient groups, talking about the surface of their lenses, for doctors asking about what do I do when we have poor surface wettability. And these patients can be, Sjogren syndrome, they could be any of these conditions, but just keep in mind, it can be those who have keratoconus and dry eye. I mean, we see this quite commonly as well. So this is really a huge issue that comes up all the time.
Yes. And you were talking about patients predisposed to these conditions. So yes, keratoconus associated with dry eye, patients that have blepharitis, demodex, and dry eyes from several conditions. Also, patients with exposure keratopathy, ptosis, nerve palsy, and eyelid repair may experience wettability issues. And there are different external causes as well, such as poor hygiene, especially the poor hygiene of the plungers, cosmetic products, and hand soap type.
When we're talking about patients who have ptosis or even missing eyelids, we fit scleral lenses for these patients. And some of them have been previously wearing bandaged lenses, same in patients with NK. And so ideally, I prefer them to daily wear scleral lenses, not sleeping in them, and using lubricant ointment at nighttime. Now, one really key important point here is in the morning, just to use a gentle warm compress and make sure the ointment is gone prior to putting on the scleral lens. Same with any viscous solutions to prevent poor surface wettability.
We have so many different management strategy for wettability issues. We will see them.
So this is a patient of mine who had, you have those patients who everything has happened with them. And I think she was the first patient who broke her scleral lens. And I was like, wow, that's amazing. She put 2 scleral lenses on one eye one time, but this is how she came in one day with the surface of her lens. But fortunately, we've gotten that under control. So yeah, the question is, what do we do? And I think managing the ocular surface and treating the meibomian gland dysfunction, demodex blepharitis in general, to your maximal level. So whatever you think is the most that you're going to do, go ahead and do that for your scleral lens wearers, especially those who have surface wettability issues.
I would like to add something. Okay, so here we know that mucins and lipids are attracted to the hydrophobic oxygen permeable scleral lens material, forming deposit and resulting in poor wettability. So selecting a material with a low wetting angle, even if often it means a lower TK, can help improve the wettability of the lens and reduce the hydrophobic areas that attract deposits. And also it's important to aggressively treat the patient's ocular surface diseases before fitting scleral lenses. And despite changing the lens design and material, the surface of the lens itself may remain compromised if the condition is not appropriately managed.
Oftentimes in severe ocular surface disease with systemic flares, which can be chronic, such as in Sjogren syndrome, these issues are chronic. And so I ask my patients, are you having a flare? Like, how are you doing systemically? And I have some really challenging cases where they have chronic systemic flares that are affecting the ocular surface and the ocular surface of their scleral lenses.
So here, patient education is crucial. Hygiene and hand washing are imperative. Research has shown that post-lens tear debris consist of high concentration of lipids. Unsurprisingly, lens surface and tear reservoir fogging issues are common in patients with ocular surface diseases. So check the soap used, avoid deodorant, scented, or moisturizing liquid soap. And you can recommend clear hand soaps, mild basing head soaps, those specific for contact lenses or those indicated for treatment of acne.
A new solution in the US, at least, which is a hypochloric acid spray for the hands, specifically for contact lenses. It's called Vibrant View, and it's the image there on the bottom left.
Okay. So do not apply makeup or oil-based moisturizer to the eyelids. Oils can spread along the skin and contaminate the tear film. You can use makeups that are not oil-based. Isopropanol-based extra strength daily cleaners are especially good at removing oils and makeup from soft and rigid lenses.
And just really important too, it's important to put contact lenses on first and scleral lenses, and then apply face creams and makeups, and then in the evening removing contact lenses and then washing the face. And just that simple act is important so that we don't get debris on the lens or in the lens.
Okay, so lid hygiene is crucial for managing lens portability. There are several products for lid hygiene. This is a list, maybe more from US products than other countries. Do you want to add something here, Melissa?
Oh, yes, this is an exciting time in eyelid hygiene. So this article came out a few years ago, and there are a few new products that are coming that I'm really excited about in the next 1 to 2 years for the eyelids that are going to be really helpful. But I'd say the most important thing is to have some sort of recommendation for your patients. The studies show that baby shampoo really doesn't work. That's not a recommendation, nor are just warm washcloths in general. So recommending some sort of commercial eyelid cleaner, some sort of compress that is helpful. But there are lots of really great products out there currently, and very exciting ones coming in the near future. So it's also important to review solutions at every single visit, going over the application solutions and disinfecting solutions, not using anything abrasive like that would have silica in it, like in toothpaste, that would damage the ocular surface. We've had a lot of problems lately in the US about solutions being on back order and then coming back and then being discontinued. So this Loba, our Optimum extra strength cleaner, is pretty much gone now. It's not available at this time. MirrorFlow was gone, but now it's back, which is an alcohol-based cleaner. But Daddi, are you having the same situation where you are, where solutions are getting hard to find?
No, fortunately in Italy we don't have this issue. We all have the solution. Actually, Boston has finished providing the solution because they are renewing the formula of their liquid solution. So we are waiting for the new formulas of Boston solutions. For other solution, we don't have any problem.
Oh, that's great.
I would like to add something here. So digital rub and rinse is necessary for good comfort and vision. Inadequate surface cleaning surface causes irregular hydrophobic surfaces that may create a debris attachment cycle. I would not use Boston Advance. I would prefer using Simplus. If the patient is already using Simplus, try Clear Care, or for European or other countries has another name. So
is it still AOSEPT or is it something different?
Yeah, the name is different. The solution is the same, but the name is
different.
Yeah. So traditional GP contact lenses, the disinfection solution are thick. and viscous, which may result in chamber debris and cause fogging on lens surfaces. So instruct patients who use such solution to rinse the inside bowl of the lens adequately with saline prior to application, and also cleaning the lens with product once a week or bi-weekly, depending on the ocular surface, can loosen and remove the surface protein deposit, bacteria, fungus, and all the deposits on both surfaces after a 30-minute soak without manual rubbing.
So Menacom Progent is really effective. It works extremely well. However, if the lens surface has tangible hydropeg, it will strip. Menacom Progent will strip the hydropeg. And so if you don't want hydropeg, then you can use it. But if a lens is not hydropeg treated, then Menacom Progent is really helpful.
Okay, you can also suggest the use of lubrication with preservative-free artificial tears over the lens throughout the day. You can also suggest to remove the lens, clean it, and reapply it, or polish the lens, but carefully, because polishing the lens, that would remove surface treatment, as you already said, Melissa. But here, interesting that what patients can do while wearing the lenses to avoid removing the lenses, especially in these times where hygiene is very important to avoid the exposure to the virus, is to wipe the anterior surface of the scleral lens when it's applied on the eye with a moistened cotton swab or scleral lens plunger. You have to place drops of lubricant in the eye or on the device and rub the surface of the scleral lens with the device.
And this is also really helpful when we're fitting diagnostic lenses and the lens surface is just completely has poor surface wettability and you're seeing all sorts of debris. I tend to use a plunger in the office, wetting it. And I tell the patients, I'm actually going to use this on your eye because it's pretty strange, and just clean that up to get an over-refraction when fitting a lens. So it's a really helpful hint, because when we're fitting lenses, we want the lenses to settle onto the scleral conjunctiva, and it would be a pain to take it out, put it back in, let it settle again. So you can use just a quick on-eye surface cleaning. And Daddi, the interesting thing, I tend to do it horizontally. I see here you're doing it vertically with the plunger. You could do it either way. Either way is fine.
This is a great point, Melissa. I don't know if you had experienced this, but we have, apart the diagnostic lenses we have in the office, I have the experience that when I order the lens and the lens is new from the lab, the first time that the patient fit the lens, the wettability is not optimal. So removing the lens and re-putting it on the eye will worsen the wettability. And this is what I do also in my office with a plunger. I clean the lens without removing it, because it will worsen that.
So when you get new lenses, for those of you new to scleral lenses, give it a good rub before you're fitting it. I mean, disinfect it, rub with solution prior to actually using the lens is going to help with the wettability. So here you can see really poor surface wettability on the left, nice wettability there on the right. And this is thanks to tangible hydropeg, which is a surface treatment that helps improve wettability. It reduces deposits on the surface of the lens. It improves lubricity, and it helps with scleral fogging both on the front surface and under the lens as well. So here's one of my favorite videos. You can see an uncoated lens, and I like to think of the gooey stuff like mascara. And you can see the lens dipped in both plasma-treated lens, and you'll be able to see all three in just a moment, but you can see how it's improved just a little bit, and a tangible hydropeg-treated lens, where you can see when it's dipped in the gooey stuff and then it comes out. And look, it's not coated and deposited at all. So here you can see the difference between the three, and which lens would you like to put on your patient? I'll let you decide that. So it's really a revolutionary, helpful surface coating. And I would say not only for scleral lenses, but some of my corneal gas permeable lens patients, it's like night and day difference. They comments like it's the most comfortable lens in 50 years, things like that. I mean, it's really incredible. also for hybrid lenses, and there are a few stock lenses in the US that have tangible hydropeg as well. So this was a study that we did. I was fortunate to participate along with two of my colleagues that looked at scleral lens wear in those who have dry eye. So we compared a PEG-based surface-treated lens with tangible hydropeg and untreated scleral lenses, and found that lenses that were treated help improve comfort, reduce dry eye, and reduced ocular surface compromise. So it was a really interesting study where each patient received a treated lens and an untreated lens and compared the comfort with that. So it sort of showed what we knew with this surface treatment.
Midday fogging is also an issue when fitting ocular surface diseases. Managing atopy and ocular surface diseases before lens fitting is needed. In some cases, reducing wearing time is also indicated. While three types of debris may occur: mucus debris appearing as small and white particles, diluted milk fogging associated with atopic disease and ocular surface diseases, and this type of fogging we may encounter with the patients with ocular surface diseases, and also we can see oil droplet debris. Debris may develop because of lens fitting, so you have to check the periphery of the lens if it's properly aligned on the conjunctival sclera, on the conjunctiva, and also limbal vault is very crucial. So you can reduce limbal vault when there is an excessive limbal clearance. Here in the OCT picture, we can see debris formation with high limbal clearance, and by reducing the limbal clearance, this allowed to clear the fluid reservoir from debris.
So just going back to the importance of solutions, there's a nice resource from the Scleral Lens Society and the Dry Eye Shop. So specifically recommending solutions for patients, adding something that might be a little bit more viscous in the bowl of the lens will help with that post-lens tear reservoir debris, and going over all sorts of helpers for handling. And this is really important at every visit. So here are some solutions that are available in the US. I would say I like to recommend an FDA approved solution. We have solutions that are buffered. We have solutions that are not buffered. My preference are single-use individual lens solutions to dispose of them after one time. All of the cases of inflammation I've seen with scleral lens wear are due to reusing the solution. And it's a little tricky when, say, in the larger solutions where there is solution left. So remind your patients that they can rinse the lens with the solution and to dispose of it after a single use. And having solutions that are easy for patients to access is really helpful. And my preference would be not to use a bottle of solution, just to use single-use solutions here.
You can use a balanced electrolyte solution to reduce midday fogging also.
So this is Neutrophil, which is one of the newer solutions that has electrolytes in it. And Jenny Vogt and team did a great study showing that this solution helped reduce midday fogging. So Neutrophil has a combination of potassium, calcium, and magnesium. It is a phosphate buffered solution, and it showed with the study improvements in comfort and also vision. And I would say clinically that I'm finding the same as well. Tangible Boost is brand new, at least in January 2021, it became available in the US. It is a monthly or more often, depending on the patient, solution that sort of rehydropegs and recoats that surface to make it more wettable. I would say that some of the patients are saying that they absolutely love it. It's something that they want to use even more than once a month. It's very easy. It comes in a little kit, and you can see the instructions here. So the tangible boost is used prior to nightly disinfection, monthly or according to the patient. In those with more severe ocular surface disease, it can be used more often.
Okay, so many practitioners may suggest their patient to remove the lens during the day and to renew the solution inside the bowl to reduce the midday fogging, to avoid midday fogging. So we had a discussion, Melissa, a private discussion with the most prominent key opinion leaders in the world, discussing this topic, if patients need to remove the lens during the day to avoid corneal toxicity or to resolve the debris formation. And there is a general consensus on avoiding taking breaks during the day because it may worsen the condition, and also it will not prevent any toxic reaction. So instead of removing the lens, clean it and fill it with fresh solution, hold the preservative-free saline on the edge of the lens and squeeze the solution into the reservoir. Here in this video, the fluorescein has been used to show how this technique allows to completely renew the reservoir liquid behind the lens.
And also for patient convenience, I completely agree with you. I'd like to avoid midday removal if all possible. But patients, they don't like taking out their lenses even before COVID. It's inconvenient. They don't want to be in a shared space with other people and have to remove and reapply lenses. And for those who wear makeup, it messes up makeup. And for most patients, they can successfully wear their lenses all day long without removing them.
Yeah, definitely. We were in accordance in allowing patients to remove the lens only if they have important vision issues. So if the patient have issues because of the debris because of lens suitability, this is the only reason to remove the lens during the day.
Got it. So here's just a reminder and to bring to your attention if you haven't seen it, if you are fitting lenses, any sort of contact lens, including scleral lenses in office. These new in-office disinfection guidelines were published last year. And for specifically scleral lenses, it's using 3% hydrogen peroxide solution, soaking it in a non-neutralizing case for 3 or more hours, and then rinsing the lens and allowing it to be stored dry. And this can be accessed it's available to everyone, but very important new guidelines here.
Well, now we have 4 books available to start fitting or deepen your knowledge in scleral lenses. This one, Melissa and I wrote it together. And Melissa's book with Dr. Lynette Jones is very useful for those who are starting fitting scleral lenses and deepen their knowledge in these lenses, because it cover all the topics of scleral lenses. The new book that I published, it covers all issues and complications, because practitioners may be intimidated by fitting scleral lenses because they don't know how to manage issues and complications. So you can consult this book, and also if book which was the first book available for scleral lenses and allowed the spread of these lenses all over the world, and it covers every aspect of these lenses. The clinical guide and Eve's book are open access, so you can download them for free from the website.
And the clinical guide for scleral lens success is available in multiple languages. So, yes. So very exciting is that the BCLA CLEAR reports are coming out shortly, and Daddi and I had the pleasure of working on the scleral lens report, which is really, the CLEAR reports, I think, are just a wealth of knowledge. So there's so much information on all of the latest research sort of condensed into these very extensive reports, but I'd encourage you to take a look at them, read them. There's also a conference coming up in June. Daddi and I would like to invite you to attend the conference virtually, which clear reports will be highlighted during the conference, and it's in multiple time zones, so hopefully it will work for everyone. But pretty exciting to be able to work on this project.
Yes, I would like to add something. The CLEAR project, the CLEAR report, is a global consensus and guidelines on several contact lenses, including Scleral lenses, in which we both collaborated, Melissa. And we will be discussing all these guidelines during the BCLA conference, and you will be discussing the Scleral lenses report, which is very, very important to follow, to read, and to participate on live and ask you questions if everyone needs to do that. So attending the BCLA virtual meeting is very important for those who want go further with specialty contact lenses. So we would like to invite you to join us in June. So in conclusion, Scleral lenses are indicated in different conditions to protect and heal the ocular surface. In these cases, the lens should be as large as possible, well aligned on the conjunctiva, avoiding limbal compression and lens suction. In these cases, the lens is more subject to poor wettability and deposit. Different management strategies are available. Fogging is also an issue, so you have to review lens design and care solution. And thank you, and we are open now to respond to so many questions here.
Before that, thank you so very much, for taking us through the importance of scleral lenses for therapeutic use. I think this is a topic which we all learn on fitting scleral lenses. Probably we know where can we use it, but there are many uses which needs to be emphasized, right? So we'll be focusing on the content-related questions. This is the first one. How large are scleral lenses that can be used? Maybe probably if you could share some light on the therapeutic use. Is there any considerations of lens diameter which you would want to take into account?
Lens diameter depends also on the physiognomy of the patient, on the palpebral aperture and the condition of the ocular surface. We talked about this in the last session. So 17 millimeters for some eyes is so large, for other eyes is not as large as possible. It's not very large. So you have to, depending on the condition for dry eye and for important ocular surface diseases, you have to fit the lens as large as possible on that eyes. I fitted lenses of 19.5 millimeters. And also in ocular surface diseases, 16.5 millimeters. So it depends on the eye condition and the eye formation. Melissa, do you want to add?
Right. So I this is such a great question, but it's such a long answer. I agree. It depends on the condition, depends on the patient. It depends on so many different things, but a range of about 16 to 20 would be just in general.
Yeah. And I think 16 because you want to save the limbal stem cells. I think you did mention about limbal stem cells as well. And if we talk about therapeutic measures, we want them, not to be affected. Probably that would be the reason you said 16, right?
Yep. So large enough where it protects the ocular surface, vaults over the limbus, does not touch it. And to very large, I think work very well. But if a patient can't handle it, if the patient has a really tiny eye, then we're going to go a little bit smaller.
Yeah. Thanks. Thank you so much. And I think this is again another question. Somebody is suffering from, I guess that's halos while driving. So what do you suggest for these patients? Would you do something in the fitting, or you would do something to the optics? Any recommendations?
Sure, I can take that. So, we can adjust the optic zone, of course, with the lens. We can include higher order aberrations in the lens. I would make sure that the lens is centered. It's not decentered as well, so centration is important.
Yes, I would like to add something here. You have to verify if there is any residual astigmatism. So if there is any residual astigmatism, you have to add it on the anterior surface. You have to verify the wettability of the lens. As we mentioned before, this might cause halos and night driving issues. And as Melissa said, decentration of the lens may induce a prismatic effect, which may affect vision also. And high order aberration are a great issue, especially in keratoconus patients. So here we need to add some correction in the optic.
Okay, all right. And in the limbal VKC, can we go for larger diameter, or is there any specific design on you would want to comment to go for? Probably in terms of design, in terms of diameter, I guess.
So I do think it's important to state here that there are multiple scleral lens designs that could work very well for many of these conditions. And so, yes, it's for this question, we don't want to touch the limbus at all. We want a ball to go over the limbus. But you could be successful with many types of designs. And it really is patient specific. And we do want to make scleral lenses as customized as possible for the specific patient. And I wouldn't say you'd be wrong or incorrect if you used say a 16.5 or 19.0. It really depends on the patient that you're addressing.
Yeah. All right. And any recommendations for patients who have undergone scleral buckling and those who wants to get scleral lenses?
I can take it, or you can, Daddi, either way. You can take it, Melissa.
Okay. It depends where the buckle is. So, these can be challenging if it's close to the limbus. So you might want to go a little smaller in diameter, larger in diameter for some patients. If it's a really pronounced buckle, doing an impression-based design like iPrint Pro is helpful. That's a good point, which also brings to the point of any sorts of irregularities in the conjunctiva at all, and refer back to our prior session that I did with Tom Arnold, and you can watch that. But any elevations on the conjunctiva, whether it's a pinguecular, pterygium, and when it comes to scleral lenses, we do want to be aware and fit lenses appropriately.
So if the irregularity is near the limbus, you have to go with the large lenses. If the irregularity is far from the limbus and you can go, you can land before the irregularity, you can fit small scleral lenses if the corneal sagittal height allows you to do that. Otherwise, you can include a vault in the lens periphery. You can introduce a notch. You can also have a customized periphery on the lens to well align on the buckling, or also, as Melissa said, you can have an impression technique.
That's right.
Many options.
Yeah, and I think the notch of the lens, I think Dr. Daddi did talk about in the last session where you showed us some lenses with the notch and I think Dr. Melissa talked about impression technology. So it's a lot of availability there on, helping these patients in getting these lenses fitted well onto the eye.
But
go ahead, Daddi.
Go ahead.
Oh, and also scleral profilometry, of course, to make lenses more customized. So we covered a lot of that in our last session. I'd encourage you if you want to see that. But there are so many different options and so many exciting options. Even in the last few years, the scleral lenses are so exciting and the technology is advancing.
Right.
So yes, notching the lens is very difficult because in Europe, at least in Italy, in Europe, very difficult to find a lab who notches the lens. I don't know how are things in your areas. What you can do is notch the lens in your office. I can prepare a video for you to show you how you can notch the lens with a very simple instrument bought from Amazon. So if you want, I can prepare this video and you share it.
Sure, that
Do you
would be
have,
great.
Melissa, do you have so many problems in notching the lens in US? Because we
No,
don't have so
we
many
don't.
labs.
No, the labs seem to do a really good job with notching, and for really elevated conditions, notching seems to work really well. So no, we don't have those problems.
Yeah.
How things are in your area, Dr.
Uh,
Fakhruddin?
Yeah, so I think with my experience, what it goes, I have not have a chance to fit a notch lens, but I think talking with your local designing lab, they are quite happy to help you out. As you said, the lab is not a problem. I think you just need to send them the anatomical picture probably, and you need to measure. As I think you were saying last time, you just need to measure and take a marker and mark that out, and that would be helpful. I have not tried it personally, to be honest, but I know they can do it for you. Yeah.
Oh, wonderful. That's wonderful.
Okay, a couple of more questions. This is again a question which comes up every time, and I just thought to put it again and see your thoughts. Larger lenses means they won't be comfortable. Smaller lenses means they are more comfortable. That's the ideological thought which people have, and so any things you want to break the myth here?
Yeah.
Sure. This is an important one. So corneal lenses move with the blink and land on the cornea. Scleral lenses don't move as much, and they go over the cornea and land on the scleral conjunctiva. So they're very, very comfortable. And my favorite reaction from a patient is, I cannot feel the lens at all. It's so comfortable. So I would say, if you believe this, try a scleral lens on yourself, and you'll see how comfortable it is.
And I would like to ask something. So why landing on the conjunctiva is much better than landing on the cornea? Because the conjunctiva is less sensitive than the cornea. The corneal nerves are so many. There are so many nerves in the cornea, and landing on the cornea, awareness of the lens on the eye will compromise comfort. While when the lens is landing on the conjunctiva, just because the conjunctiva is less sensitive, the patient will not feel the lens on the eye, and also the interaction with the eyelids. The eyelids going on the corneal lenses, because they are smaller, there is a more awareness of the lens on the in the eye. With larger lenses, this interaction is much less than corneal lenses, and the awareness of the lens is lessened. So these are the reasons why scleral lenses are more comfortable than corneal lenses.
That's right. And I think very good point. You should try it out yourself first. And that helps a lot. I did try putting in scleral lenses. Same like doing visual field, you must do a visual field test first to experience how your patients will feel. I think it's the same with scleral lenses as well.
Mm-hmm.
Yeah. And looking at the next question, post-penetrating keratoplasty, we recommend scleral lenses. Is it for avoiding foreign body sensation or to relieve pain? And I think probably both of the above, or anything you would like to add on?
Yeah, so very commonly patients will say that their eyes feel more comfortable with a scleral lens after a PK.
Yeah. Okay. And one last question before we wrap up for today. Will it be a better option if patient have mild dry eye? Which lens is RGP, scleral for refractive correction?
It,
This depends on the patient's needs and the patient availability in paying the lenses, because there are different, the economic aspect is different between RGP and Scleral lenses. You can start with RGP and see if the patient is happy with them. Otherwise, if there is overall satisfaction is compromised, you can switch to Scleral lenses. Here depends on the patient's needs and sensation, so comfort.
and is the dry eye managed? In all these patients, of course, we want to manage the dry eye even with scleral lens wear. So if the dry eye is managed and they are comfortable with corneal RGP lenses, that's absolutely fine. And often, this question sort of makes me think, how often do they want to wear contact lenses? Is it all the time? Is it sometimes? What do they want to wear them for? Would we want to fit a soft lens or a hybrid lens? We have all sorts of options for this sort of patient.
That's right. And I think this question reinitiates me to referring back a previous session by Dr. Daddi, where she took us through patient selection. You need to select the patient well. It's not just because now what happens is everybody is saying scleral lenses. People, I think some of them start thinking that they are the best lenses in the world. And all A to Z patients, I would fit scleral lenses. But probably that may be true, but it's not clinically true, because you need to look at your patient selection, right?
It should not be true at all, actually, because there are many types of lenses, and not all patients are candidates for scleral lenses.
And before starting scleral lens fitting, you have to manage the expectation of scleral lenses. Just because everyone is talking about scleral lenses, so patients are thinking maybe scleral lenses will resolve also their arm healing. So expectation very, 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 very high. So you have to manage these expectations, and you have to explain the limits of scleral lenses also.
That's right. So that's really important. So thank you so much, Dr. Daddi and Dr. Melissa, for doing this. I know it's a very early morning for Dr. Melissa, and I think the passion of teaching shows is through. It's 6:30 we started, and now probably it's about 7:45 at your end, and still energetic. And Dr. Daddi, it's afternoon for you. Probably we are in between your lunch break, or you probably just had your lunch and you want to have a rest. But I do understand that the passion of teaching, what both of you have, has always helped all of us. Thank you so much for doing this.
Thank you
for having us.
Most welcome.
Yeah, having us, and I would like to thank everyone who joined this session. It's night for someone, it's morning for others, afternoon for other people, it's lunchtime for some of them. So thank you everyone for joining.
And thank you for joining from all over the world. That's awesome. And thank you for all the really nice comments in the chat. We appreciate it.
Yeah, thank you. Welcome. So thank you everyone again. We do have session planned next weekend. Thank you so much for attending today's session. Thank you to both of our speakers for giving us this time. I will see you all again next week. Take care, be safe, and bye-bye. Bye. Thank you.